kind behind. I think we have to stop talking, and in 2 minutes I'll start introducing you.
Okay.
Thank you so much.
Ignore it, please.
Καλησπέρα σε όλες και όλους που για μια ακόμη φορά είναι κοντά μας για να ακούσουμε μία ακόμα εισήγηση πάνω στο θέμα υγεία και θρησκεία από διακεκριμένους ομιλητές από την Αμερική και από την Ελλάδα. Σήμερα έχουμε την εξαιρετική τιμή και χαρά να έχουμε τον καθηγητή John Petit από το Πανεπιστήμιο του Harvard, ο οποίος θα μας μιλήσει για ένα πολύ σημαντικό θέμα. Ο καθηγητής Petit τελείωσε την ιατρική σχολή από το Πανεπιστήμιο Columbia και μετά είχε την εκπαίδευσή του στο Massachusetts Mental Health Center και έκανε και μία ειδικότερη εκπαίδευση στο Peter Ben Brigham νοσοκομείο, που είναι και αυτό νοσοκομείο του Πανεπιστημίου του Harvard. Εδώ και 40 χρόνια είναι ψυχίατρος και διευθυντής διαφόρων προγραμμάτων στο νοσοκομείο Brigham Women's Hospital, καθώς και στο αντικαρκινικό νοσοκομείο Dana-Farber Cancer Institute. Όπως είπαμε, είναι ένας από τους πιο γνωστούς ψυχιάτρους στην Αμερική, είναι πολυβραβευμένος, μεταξύ των οποίων έχει πάρει το τίτλο του Distinguished Life Fellow του American Psychiatric Association. Έχει πάρα πολλά βιβλία γράψει, πάρα πολλά περιοδικά και μπορεί κανείς να τα δει στο site του. Έχει δεχθεί το APA's Oscar Pfister Award και ήταν ο προηγούμενος πρόεδρος της Αμερικανικής Ψυχιατρικής Εταιρείας στα θέματα της θρησκείας, πνευματικότητας και ψυχιατρικής. Σήμερα θα μας μιλήσει με θέμα πνευματικότητα και υγεία, ποιος είναι ο ρόλος του γιατρού. Professor Petit, I introduce you in Greek. I know sounded all Greek to you, but we are very happy and privileged and honored to have you today as our main speaker on a very interesting topic on spirituality and health. What is the physician's role? We're all ready to listen to your introduction and at the end allow us to ask you some question. Thank you again for the honor, and we are ready and the floor is yours. Thank you.
Well, thank you very much for this invitation, and I'm honored to be part of this course. Let me see if I can share my screen. Are you able to see that?
Yes, yes. Perfect.
Okay. So I'd like to cover these areas in the time we have. A little bit about history, the spirituality medicine interface now, some working definitions, a little bit about emerging relevant research, some potential roles for a physician in a patient's spiritual life, 3 roles, and then a little bit about clinical and ethical challenges in addressing spirituality and treatment before we have some discussion. I'm coming at this from the American context and also from a psychiatric context, so my presentation will be a little bit skewed in those directions. So maybe we can have some correction for that in the discussion. This is a depiction of the Temple of Asclepius, which, as you know, was a place where healing and worship were combined, which was the case in the priestly role that many healers had for centuries until the Enlightenment, when we've had people like John Locke emphasizing that knowledge comes from the physical senses, and Isaac Newton, who pioneered explaining complex phenomena in terms of their summative parts, which led to a more reductionistic, dichotomized view of the self and of medicine. But medicine and spirituality now, after a long period of neglect, especially within psychiatry, where Freud was hostile to religion, has, as you can see from this list, developed a number of points of commonality. 12-step spirituality, for example, in Alcoholics Anonymous, is widely valued. Palliative medicine includes spiritual care among its goals. Psychoanalysts such as Anna Maria Rizzuto have had a better understanding of faith than Freud did. Mindfulness has become mainstream within American psychiatry. There are a number of courses, papers, books, which have proliferated, including on the neurobiology of spiritual experience. Spirituality is seen as a risk and a protective factor often now. And most patients surveyed say they want their religion or spirituality included in their treatment. The American Psychiatric Association has created a mental health and faith community partnership, bringing together faith leaders and providing information for churches and synagogues on how to recognize and refer mental health problems. The World Psychiatric Association and the Royal College in the UK have also made statements on the importance of religion and spirituality in psychiatry. And if you've heard from Dr. Koenig, you know that research has burgeoned in this area. And there are a number of ways to access that. This is just one that I've listed here. And these are a couple of examples of recent publications. This one on spirituality and serious illness and health came out in the Journal of the American Medical Association as a systematic review of the literature in these areas with some consensus recommendations. And the other one in JAMA Psychiatry is a paper by Tyler Vanderweel at Harvard, reporting on the Nurses' Health Study, which showed a 5-fold reduction in suicide in almost 90,000 women followed from age 30 to 55. The reduction was in those patients who attended religious services regularly. But there are a number of reasons that clinicians continue to neglect spirituality in their practice. There's a lack of consensus about definitions. Inexperience and lack of training is a major factor that the research points out. Our own responses to this area, not wanting to be involved in having to talk about our own unresolved spiritual concerns, can be a factor. Lack of time, certainly, in many specialties. Sometimes clinicians are concerned about boundaries, wondering what their role is really in the patient's spiritual life, not wanting to be seen as crossing an appropriate professional boundary. So to go back to the issue of definitions for a bit, There's no universally accepted definition of spirituality, but usually we think of it as one's relationship to the transcendent, whether it's God, beauty, ultimate values that gives one's life meaning. And this ambiguous definition makes research difficult. It's easier to measure parameters of religion as a more organized tradition of spiritual beliefs and practices shared by a community. It's generally associated with better health outcomes, but it can involve struggles or distress. Freud coined the term Weltanschauung, or worldview, to refer to someone's intellectual construction, which solves all the problems of existence uniformly on the basis of one overriding hypothesis. And others since have distinguished four major worldviews: radical materialism, which Freud represented, secular humanism, pantheism, and monotheism. But in practical terms, there is also a sense in which religion is whatever we organize our lives around, whatever we worship, in the sense of devoting our time and our efforts and our attention to this and organizing our life. Just to summarize some of the serious illness literature, the data suggests that religion and spirituality are important to patients, and they're associated with improved coping with illness and quality of life. Many, though not all, want religion and spirituality to be acknowledged in their care, but practitioners don't seem to be performing spiritual care very much. There's growing support for the incorporation of religion and spirituality into patient care. I mentioned the Joint Commission in the US, which mandates routine spiritual assessments. The American Academy of Medical Colleges includes some education on this in their requirements, and medical associations recommend screening for spiritual and religious dimensions of care. Some of the examples of the National Cancer Institute and the National Consensus Project for Quality Palliative Care. And that latter group has recommended assessing and addressing spiritual concerns, recognizing and respecting spiritual beliefs, providing spiritual support, and allowing the participation of spiritual communities in patient care when it's desired by the patient or family. So now I'm coming to three potential roles for a clinician in a patient's spiritual life, more specifically. The first is understanding the patient more deeply. The second is responding to distressing spiritual problems. And the third is helping patients become more integrated and whole. Spiritual assessment, I think, offers a window into a patient's core values, culture, relationships, sometimes trauma history, resources and practices that can be helpful during times of illness and stress, and ongoing supports, especially in a community. There are a number of instruments for assessing spiritual issues in patients, but I usually like to think of three primary elements. Listening for what's valued, sacred, or deeply troubling to a patient, in the words they use, like courage, despair, comfort, suffering. Those give you clues as to where these issues may be important. And then asking, perhaps, are you a religious or spiritual person? What's the most important aspect of your background or identity as you listen to their story? What gives you peace? And then more actively exploring by following up on these clues that you have on what practices help to replenish the person spiritually. If they mention God, what is their relationship to God like? How do they envision God? And then asking about struggles with guilt, disappointment, or doubt that are distressing to them. Just to list some of the spiritual problems that can be associated with physical or mental health risks. We're familiar with Jehovah's Witnesses' refusal of blood products, and Christian Scientists' sometimes refusal of the medical in favor of prayer and faith. There are religious extremist cults such as Scientology, which pick at the annual meeting of the American Psychiatric Association on a regular basis. There are religious patients and families' pursuit of miraculous healing at the end of life, which is associated with more aggressive care at the end of life. There's a reinforcement sometimes of unhealthy guilt or passivity, resistance to treatment for conditions such as depression when it's regarded as something that's spiritual or some kind of possession. In the case of bipolar disorder, there's sometimes over-scrupulosity, which is reinforced by religious practices. There can be rigidity or religious and spiritual struggles. And just to say a little more about struggles, which has been written about in a recent book by Ken Pargaman and Julie Exline, they've classified these into divine struggles, such as, why did God do this to me? Demonic struggles, when people feel they're engaged in some kind of spiritual warfare. Interpersonal struggles, if they've been abused by individuals within the person's faith community. They can be troubled by doubt about how the universe works, what's fairness. Morality, distress at others' failures to live up to their values and their own moral standards. And then just questions of ultimate meaning. What is there that's ultimately meaningful in the universe, and where can one find that? These issues come up for patients at the end of life, as many of you know, and often even sooner when there's a significant stress in the person's life, especially. I mentioned the whole person mission of palliative care, which here, quoting the National Consensus Project, says, it aims to identify and address the physical, psychological, spiritual, and practical burdens of illness. So here's a case example. The team requests urgent evaluation of the mother of a 5-year-old girl with leukemia. On learning that her daughter has relapsed, she becomes distraught and asks, why did God do this to me? So in responding to this patient as a clinician, you might probably want to find out more. Is this just her idiom of distress? Does she have a relationship to God that's been characterized by trust in the past or betrayal in the past? Does she have some other history of betrayal and trauma in her family that's being expressed in this way? Without finding out more, you don't really know whether this is a theological question or a question with more emotional roots, and what she needs in that instance. Does she need to be heard out, listened to? Does she need a referral to a chaplain? So again, a indication of a need for more assessment. So some of the ways to address spiritual struggles in psychotherapy could be to just try to become some kind of trusted guide for them, to be present to them in their spiritual struggles. Hospital chaplains talk a lot about this practice of being present with struggling patients, to name and normalize spiritual struggles. These are common, they're understandable, and then to facilitate acceptance and reflection and help them access resources if they do need to talk with someone from their faith tradition or a more generally available hospital chaplain. Here's another case example from our consult service. Surgeons requested help approaching a single woman in her 50s who was reluctant to consider potentially curative surgery for newly diagnosed breast cancer. She appeared anxious, but said she was putting her faith in God to heal her. And when they asked for our advice, one of our fellows responded with, I think, some helpful suggestions, even before we had a chance to see and assess what was going on with her. He suggested that the team acknowledge the importance of her faith to her, agree that physicians treat while God heals, indicate that many members of the hospital team are people of faith, and offer to include her spiritual supports. Daniel Solmesi, who's a palliative care physician, has written a helpful article about this, spiritual issues in the care of the dying, in JAMA, 2006. And then the third role, helping patients become more integrated and whole. I think it's helpful to think of spirituality and as a response to existential concerns, and fostering a helpful spirituality as a way of helping patients with issues related to identity, hope, meaning and purpose, morality, and autonomy in relationship to authority. Some of these existential domains where patients present needs in the course of their medical care. So some of the clinical implications of identity: core beliefs about who one is in the world are important at points of change. Illness can cause patients to reassess who they are. A successful businessman who suddenly has a heart attack is going to need to reassess what's really important to them, what's valuable about who they've been in life and what they want to do. Patients may or may not trust clinicians based on who they perceive them to be. But a spirituality can ground someone's identity when it's engaged and transformative rather than static. I'd like to show a little clip, if I can, of an example of this. Marshall Linehan is a psychologist who developed the dialectical behavior therapy approach to borderline personality disorder, the best evidence-based treatment that we have. And she gave an interview to the New York Times sometime back about her own experience coming out of psychiatric hospitalizations in which she was harming herself, suicidal. Let me see if I can stop sharing and bring up the clip. Can you see that?
Yes.
In the sitting room, right outside the chapel, which I will never forget, because I was sitting on the couch and I think I felt complete and total despair is the only way to say how I felt. And so this nun walked by and she turned and looked at me and said, is there anything I can do for you? And I realized that no one could help me, that just no one could help me. So I said to her, I said, no, thank you. And she left. And so I got up and I went into the chapel. And I was just kneeling there. And I have no idea. I doubt seriously I was saying anything. I think I was just looking at the cross above the altar. And then out of the blue, out of the absolute blue, suddenly everything went gold and the crucifix started shimmering and the room was shimmering. And I had this unbelievable experience of God loving me. And I jumped up and ran out and ran to my room. And I was standing in my room and I said, I think out loud, I said, I love myself. In the very minute, the word myself came out of my mouth, I knew I had been completely transformed. Because up until that point, I would have never said that. I would have said, I love you, because I had no sense of myself. I thought of myself as you. And the minute the word myself came from my mouth, I knew, and I've always known ever since, that I would never ever cross that line again to being present.
Can you see the slides again?
Yes, very well.
Okay. Oh, sorry.
Go ahead.
Sorry about that. So there's a lot that could be discussed in relation to that clip, and maybe we can come back to it in the discussion. But one thing that always strikes me is how her sense of being loved by God gave her a kind of grounding and a sense that she had a self that could be different and connected to others. In the DBT treatment approach, she's incorporated other elements of spirituality, such as Buddhist mindfulness. We can talk a little more as we go along about mindfulness. Hope is another important domain of existential concern. Patients are often disillusioned with God or their own ideals when they're depressed or stressed. Different worldviews offer different hopes, especially at the end of life. And clinicians can influence hope through empathy, clarification, lending their own hope when someone is suicidal, for example. If someone has a spirituality that's integrated rather than ambivalent or torn, it can foster hope. Judith Herman, in her book, Trauma and Recovery, talks about how it's important for patients to rebuild their worldview, their view of life as part of their recovery. Meaning and purpose. Patients often present searching for purpose and meaning in their suffering, and clinicians can often help them look for answers in a worldview. A shared worldview offers potential for intervention based on common ground and knowledge of the patient's tradition, but also unique risks of crossing boundaries and becoming some kind of spiritual authority for the patient when someone else should really be playing that role. A spirituality that's attuned rather than distracted can open one up to meaning and purpose and to thinking about these ways of finding meaning in one's life. I mentioned before this literature on mindfulness and mental health.
Today's enterprises must have the ability to adapt to ever-changing digital demands without compromising performance, security.
And the literature on mindfulness and mental health has actually shown more results in anxiety reduction than it has in measures of meaning and purpose. But you can see how it can open one up to spiritual sources of meaning. Morality is another important domain of existential concern. Worldviews influence one's core commitments, ways of understanding and dealing with moral failure, preferred virtues. We hear more about moral injury these days. Clinicians can help patients take their worldviews into account in dealing with moral struggles and injury. Although clinicians' own values influenced by their worldviews also shape the direction of their work, and it's important for us to be aware of that. But a spirituality can foster a morality that's mature rather than developmentally delayed. Chaplains sometimes talk about how they have to help patients they see update their spirituality, their view of morality from what they learned in Sunday school as a child to something that's more developed and adult. Robert Cloninger, who's a scholar of personality disorder research, has outlined this progression from more immature, self-centered morality to more contemplative, other-directed morality, which you can also see in the 12 steps of AA, which move toward giving back. And then finally, there are some clinical implications of autonomy in relation to authority. Religious and secular individuals often differ the most here. Autonomy is a relative value for those loyal to a higher authority, and clinical struggles sometimes emerge for patients in dealing with medical aid in dying, abortion, adolescent sexuality, or same-sex relationships. And clinicians can sometimes be asked to act in ways that may be challenging for their own worldviews in these areas. But a spirituality can foster feeling loved rather than rejected by the other. Every tradition has ways of being reconciled and forgiven. This is a depiction of the return of the prodigal son, for example, in Christianity. So knowing how patients can access these resources for being reconciled to the authorities in their life is important to know about. So to summarize, spirituality in relation to existential concerns and positive psychology. In these existential domains, spirituality, if it's helpful, can help them to be engaged, integrated, reflective, mature, feel loved, and then have a healthy self that's more grounded, hopeful, visionary, virtuous, or forgiven, feeling intimate or secure. Here's a case example of a patient I've had, a 65-year-old divorced abuse survivor presented with a history of hospitalizations for suicidality, estrangement from her family, disillusionment. She actually had gone to seminary later in life. She had a lifelong love of nature, but she felt no longer able to believe in a God who had allowed her to be so damaged. Medication and cognitive behavioral therapy were not particularly helpful, and the insight helped her only somewhat. It was helpful to provide her with consistent support, for her to volunteer in a nature museum, so that she stabilized, but she continued to struggle with whether her troubled life was worth living. She eventually tried meditation in a Buddhist community, but she didn't feel able to really connect there. And then after a few years, she was able to find a small Christian congregation where she could feel accepted and loved and heard. And that actually had a quite transforming impact on her mental health. I'll use this as a segue to talk a little bit about faith communities and mental health. We know that pastors and chaplains counsel individuals with many types of emotional, relational, and addictive problems. In fact, 39% in one survey said that they turn first to clergy for their emotional problems. They tend to be more trusted, accessible, affordable. We know that faith communities offer meaning, belonging, forgiveness, ways of giving back through shared transformational experiences, service opportunities, and programs in the US such as Celebrate Recovery, which is a Christian 12-step program begun at Saddleback Church. But faith communities can also reinforce mental health stigma and the view that it reflects simply a spiritual weakness in need of more prayer. So I'd like here to describe a spectrum of spiritual involvement in psychotherapy, from the clinician who's spiritually avoidant, doesn't ask these questions, doesn't feel it's part of their role, to someone who you could say is basically competent, able to do an assessment and formulation, to someone who's more spiritually conscious, recognizing the patient's spiritual needs, refers them to resources. Someone who's spiritually sensitive might begin to think about integration and collaboration. And then someone who's a spiritually oriented clinician, therapist, pastoral counselor, might actually get involved with things such as spiritual direction, refer someone for healing prayer. The question of how to integrate these into traditional psychotherapy is something that's receiving more attention recently. Here's an example of a program to integrate spiritual care into cognitive behavioral therapy in an acute psychiatric setting at McLean Hospital, which is one of the Harvard teaching hospitals. David Rosmarin published this paper some time back now, over a decade ago, in which he found that having patients integrate their own tradition into their cognitive behavioral therapy was quite well accepted. And he's since taken that into the development of a spiritually integrated therapy program for inpatient, residential, and intensive treatment settings, which has now been studied in over 1,400 patients, basically offering patients a chance to talk about the relevance of their faith for their mental illness and offering them a menu of ways that they may want to integrate it in a helpful way. And he currently has a Templeton Foundation grant to train clinicians in this approach in the Boston area. It's not just a Christian thing, though. Spiritually integrated therapy is also practiced in the Muslim context on the West Coast of the US. There are some Khalil centers which involve having imams and clinicians in a clinic setting help patients whose spiritual concerns are very intertwined with their mental health issues so that they can talk about both in a trusted context. Some of the ethical and clinical challenges that come with integrating these areas, medical, psychiatric, spiritual issues, are the potential for undue influence, confusing spiritual and psychological realities, becoming a spiritual authority for someone, as I mentioned before. The question of boundaries, informed consent, self-disclosure. Should you see someone who is also in your congregation? Some of these issues have also been discussed in the literature that's out there now. Some have cautioned about the promotion of faith for its health benefits, which can distort its essence. We know that in general, being more religiously involved is helpful to one's health, but so is being married, and we don't recommend marriage just because it's better for your health. The question of competence. Richard Sloan at Columbia has criticized the integration of spiritual care into medicine on the basis that clinicians are really not competent in this area, and we should leave it up to the spiritual care specialists. And then there are issues of transference and countertransference, psychiatric terms for the emotional responses that patients and clinicians can have in the process of therapy that addresses these highly intimate and sometimes charged areas. More specifically, some of the boundary considerations that come up are self-disclosure. How much should one say where one is coming from as a clinician spiritually? The guidelines are usually to keep self-disclosure to a minimum in psychotherapy, but recognize that it is appropriate at times, for example, about one's qualifications, and that it can sometimes have an important therapeutic impact. The important thing is that it needs to be well thought out and that the disclosures serve the patient and not the therapist. I've mentioned dual relationships. If you have a relationship with a patient on a spiritual basis and a clinical basis, that can cause boundary confusion, role confusion. But whether a boundary crossing is harmful and a boundary violation depends on careful attention to the clinical context. We shouldn't be reflexive in the way we think about these things. Gutile and Gabbard have a good paper about this. And then transparency and informed consent, why one is or is not dealing with the patient's spiritual concerns, can also be helpful in maintaining appropriate boundaries. I'll just mention some resources within the psychiatric world. The American Psychiatric Association has a caucus on spirituality, religion, and psychiatry. The American Psychological Association has a large Division 36 devoted to these issues. They have a journal. They've published a number of books. The Royal College in the UK is a large spirituality interest group. I mentioned the APA Mental Health and Faith Community Partnership and their resource guide, and the World Psychiatric Association, which has had a number of global meetings on these issues in places like Jerusalem, Brazil, India, and has another one planned for next year, I believe. There are also some training programs for competency in mental health that are available now, originally funded by the Templeton Foundation. And finally, I'd like to close with a quote from William James, who is our local hero for his classic book, The Varieties of Religious Experience. He said, "Religion is a man's total reaction upon life." Today, he might say spirituality. And then he also said, "My thinking is first and last and always for the sake of my doing." He was known as a pragmatist. And I think as clinicians, it's helpful for us to be focused on what's helpful to the patient, what in this huge area of spirituality and religion is going to be of practical use in their care. So I'd like to stop there and see if there are questions or some. I think we have some time for discussion.
Thank you so much for this great presentation and review of so significant topic. Let me rush to some questions that we receive. The first one is reads in translation from Greek. What would be your answer to the question, why did God do this to me, by a reasonable spiritual, in quote, mother that lost her 18-year-old child on a train accident? By the way, that happened yesterday in Greece, and so this is a real question.
Yeah, I'm so sorry to hear about that. It's terrible. I don't think any of us can really answer those questions. I think we can explore where the question is coming from and what the feelings are, join in the person's pain and questioning spirit. Think with them maybe about where they found answers in the past, where they would be hoping to look for more comfort. Give them time to process it in a place that feels safe to them. I don't think any of us has an answer that we can really give. There are people who've offered theological responses to the question of theodicy, but I think in a context like this, it's not really helpful to try to be so abstract.
Yes. The other question is as follows. We hear about the spiritual history. How do you take it? What questions do you ask?
Well, I have the luxury of time and taking a person's whole story within a 50-minute initial encounter usually. So I'm fortunate in relation to most other clinicians. And so I usually listen and hear what's really most important to someone and then follow up. I do tend to ask as a routine question, have you been a religious or spiritual person? And see what they say in response to that. And then if it is important, I try to listen for how it's important, how it might have been a problem. I think if you're in a much more time-constrained setting, you can still ask have you been a religious or spiritual person? Is there something about your spirituality that's important for us to know about and taking care of you? Even if you're going to be helping them with some medical issue.
Okay, great. Then the other question reads as follows. You have focused on the role of a psychiatrist in a patient's spiritual life. What more might you want to say about the role of a general physician, of a GP, of internist?
Yeah, well, as I just mentioned, I think asking, as you get to know the person and what's most important to them, you can ask that as part of a screening question. If you know that they're going to have issues with serious illness and decision-making, you can then ask more about who the resources are, what are the values that guide them in making challenging decisions. I think those are the areas where it tends to come up more, serious illness, than in your average GP context. But there is a book that was published by Oxford a few years ago. Michael Balboni and I edited it on the way that these issues come up in different medical specialties. There are chapters by surgeons, pediatricians, palliative care physicians, psychiatrists, and then also some chapters by people in different academic disciplines like law, philosophy, sociology, looking at this interface in different from different angles, not just from the mental health angle from which I've been talking. So there's a literature out there if you're interested in some research in many of these other specialties now as to how it's come up and what sort of the best practices are within that specialty.
Thank you. Then I think this is the last question. Knowing that in Greece we don't have many hospital chaplains, could you speak to the role of hospital chaplains in meeting spiritual needs as part of the clinical team?
I can say in the US, most major hospitals do have a hospital chaplain service, which is interfaith. They're sometimes able to draw on spiritual guides from other traditions. For example, at the hospital where I am, there's an imam on call and Catholic priests who can provide sacraments to patients in the hospital. And then the outpatients also have some availability, less so to chaplains. I think many places try to rely on community clergy to come in and see patients. And if someone has a good connection with the pastor, then of course that's the best thing for them to come in, and members from their own congregation. But there are many patients we're finding who are not connected to communities outside who still can benefit from a hospital-attached spiritual care specialist who can sit with them and help them explore these issues. I don't know how it works in Greece, how well developed that is. I know here in the US, the chaplains are funded differently depending on the values of the hospital. Some are pretty well-funded staffs and they have training programs. Others struggle to be able to see enough of the patients who want to see them. And the chaplains can also be a resource to the clinicians when these issues come up for clinicians. The clinicians want to know what to do with them. Chaplains can sometimes coach them on how to talk to the patients about these issues. At our hospital, we have the palliative care chaplain join us on our rounds when we meet to talk about the patients that the psychiatry service is seeing who have cancer. We identify the patients ahead of time who we're both seeing, the chaplain and our service. And then at rounds, we can talk about what we're each doing with them. The chaplains can say what they're doing with them, and we can say what we are, and we can learn from each other. That's been a useful model for trying to collaborate and be less siloed.
So you think that the institution of chaplainship is very important for the benefit of the patients?
Yeah, I think particularly in serious illness, the palliative care team typically has a chaplain that's part of their rounds, sees a number of their patients as a resource for them. And but they're, of course, seeing more seriously ill patients.
Great. With that, we want to really express our gratitude to you, Professor Petit, and thank you once again for giving your expertise and your time to us. Thank you so much.
Thank you.
Thank you. Bye-bye.